to this learning. So we shall have a number of people for this session today. We shall have critical care nurse, we shall have doctors, and in this time we're just going to have introductions from the panel that is present and the panel that is online. We have some team online and some team that is with us here. So I'll start with myself. I am called Dr. Ann Kaguna. I am an emergency medicine resident in year 2 at Makerere University, and I'll be our moderator for this session today. I must say you're all welcome. Next to me is Dr. Sande. Kindly introduce yourself.
Good afternoon, our listeners. My name is Dr. Chituraga Isande, emergency physician working with the Ministry of Health. I'm glad to be here today to share experiences in emergency medicine. Thank you.
Thank you, Dr. Sande. Next, we shall have Ms. Nazinda Moli introduce herself.
Yes, good afternoon, everyone. My name is Nazinda Moli Grace, a critical care nurse working with Rubaga Hospital. Nice to meet you, all of you. Thank you.
Thank you, Molly. And next, we have Dr. Harry, who is joining us today as an emergency medicine physician. You're welcome, Dr. Harry.
Thank you, Dr. Anna. I am Dr. Harry Chen. I am an emergency physician, and I am a SEED Global Health Educator at Malago and Makerere in emergency medicine.
Okay, thank you, Dr. Harry. Then we have some facilitators who are online. We have Dr. Maria. Kindly unmute yourself and introduce yourself to the team today.
Good afternoon, everyone. I'm Dr. Maria Somplana Subuga, a medical officer working with Case Hospital and Rocket Hill. Thank you so much. Glad to be here.
Okay, thank you, Dr. Nansuga. Glad to have you online. Next, we shall have Dr. Hans, all the way from Moroto. You're welcome. Kindly introduce yourself.
Thank you. My name is Dr. Hans. I'm a general surgeon. I work in Moroto region.
Okay, thank you, Dr. Hans. Lastly, we shall have a representative from SEED Global give remarks and introduce himself. Welcome, Dr. Gaba.
Yeah, thank you, Dr. Ann. My name is Dr. Gaba Brian. I'm the clinical advisor for SEED Global Health. Welcome to yet another session of the Emergency Medical Services ECHO. You're all welcome, and thank you for tuning in every 2 weeks to attend these sessions. I have 2 pieces of communication. One is about the REACT teams. REACT team stands for Resuscitation Action Teams. This is an initiative to create and train a group of staff at several hospitals to improve care for emergencies. So this process has been ongoing. Teams have been formed in almost all facilities, except Mubende and the Greater Kampala, which is going to go on in the next few weeks. If you're interested in those teams, I don't think it is too late. And if you're a regular attendee of these sessions, you can request your hospital facility and be included in the team if you have a passion for emergency medical services. Following on the creation, we shall be training the teams and the staff who have been constituted on the teams at their facilities. Trainers will come to your facilities and train you on emergency medical services. Secondly, issuance of certificates for the last phase of the ECHO sessions is ongoing. Keep calm, your certificate will reach you if you're eligible. And just to remind you, eligibility is if you've attended the vast majority of the sessions, which is 5 out of 7. We've had queries of people complaining and yet they have not attended the sessions. If you have, you will receive your certificate soon. I wish you all a wonderful and informative session. Back to you, moderator.
Thank you, Dr. Gawa. Once again, I want to say you're welcome to our online team, everyone that has tuned in to listen to today's session. We are studying about blunt and penetrating abdominal trauma. We shall have a case by Dr. Nansubuga that will be presented shortly after our pre-test and getting expectations from the team. Just a reminder, in case you're tuned in, we request that you stay muted and kindly turn your video off. In case you have a comment or question, you can raise your hand up in the chat and also send a question directly. Thank you. We shall have our pre-test running for the next 5 minutes. So kindly fill the pre-test and then give us your expectations of the session. It will be very helpful for us as we are running this meeting today. Thank you. Keep the answers coming in, keep the expectations coming in, and we'll work on it.
I think it's okay to type, right?
Okay. You can also raise your hand up and tell us what your expectations are for this session. You can unmute and tell us what you think you expect to learn from today's session.
I can say in
Dr. Alinda? Alinda Isaac, do you mean to tell us something?
yeah.
Okay.
Good afternoon. Hope everyone is hearing me.
Yes, you're very audible. Thank you.
My expectations for this session is that I would like to, like, at the end of the session, get that confidence, like when I'm dealing with my patients on the ward, when I'm dealing with someone who has an abdominal trauma. Like, I am sometimes like so nervous before I head up with someone having an abdominal trauma. But I think by the end of this session, I will have the confidence to do that. Thank you so much.
Thank you, Alinda. Glad to hear your expectation, and I hope we are able to fulfill by the end of the session. Once again, a reminder, if you're tuned in, please turn off your video and only unmute if you're saying something. Thank you. Rugumayo, Richard.
Thank you very much. My expectation is, as we're handling the blunt traumas, in most cases they end up in theater. So I expect something to deal with anesthesia and to get more on how we can handle these patients. Thank you.
Thank you, Mr. Rugumayo, either doctor or whatever the title is. Thank you. Mr. Nsubuga Yakobo, kindly unmute and tell us your expectations for the session.
Thank you so much. This is a great initiative. Thanks to ECHO and the entire organizing committee. My expectations from the entire team, I would like to hear that part of improvisation, away from what is conventionally known from the textbooks. So comparing it or versing it with in a low resource constrained area, how best would you manage such cases? Thank you so much.
Thank you so much, Mr. Nsubuga. That has been noted. I'll take only 2 more expectations and bring this to a close. So I'll take Twesige Julius and Habib Atayo. Atayo, you go first.
Okay, thank you very much, team, for this session. My expectation is that by the end of the session, we should be able to really know the emergent things that someone can really offer to these kind of patients, right from the doctor's perspective and even the nurse's perspective. What can the nurses do even when we are not yet ready maybe to offer the surgical help that is needed? What can they do as we wait for other processes to take place? Because we know, as a colleague said earlier, in our resource constraints, there are a few things that sometimes we are not able to do as they are recommended to do, but there are things that can really be done to save someone's life, to prolong someone's life. That's what I really expect to get at the end of this session. Thank you.
Thank you, Mr. Tayo. That has been noted, and I believe Dr. Sunday will be very resourceful in that area. Next, Twesije.
Thank you very much. Good afternoon, everyone. I think mine is also same as my colleagues. I want to know that part whereby a person has not yet reached theater, what those emergency things one can do, and what indicators can you see about a person that maybe this person has an internal injury. What are those signs and symptoms we can really do at the lower level, like at a health center 3 or 2? What can we do? Thank you.
Thank you so much, Mr. Twesije. I'll take Peter Kiria last and then bring this to a close. Kiria Peter, kindly unmute yourself and give your expectation.
Thank you very much for the opportunity, and thank you for this initiative. My concern, some of these traumas are preventable, and I'm actually thinking, do you have a bit of public health aspects of these events? Are you going to talk about in some ways that we can prevent actually getting these traumas before we even think of this other management? I think it's an area that we always don't talk much about. We are always looking at a person who has already been injured, and we are trying to save life. But I mean, if we also prevent the preventables, we can reduce on the number of people who are coming in to make us for us to actually attend to them in such a way, in such a critical way. Thank you.
Okay, thank you, Mr. Kiria. Your comment has been taken note of. I hope our panelists today will address those sessions. So thank you to everyone who has conveyed their expectations of this session. We hope that we are able to meet them throughout this time we are having here. So as we get ready for the case presentation, I'll ask Dr. Nansubuga, kindly share your screen. We shall have a case presentation of someone who sustained blunt abdominal trauma, and we shall listen to how care was handled from the time of presentation up to the time of discharge or disposition. And I believe it will shed a light on how care is handled for blunt abdominal trauma. In case you have a question about this case, kindly follow it clearly. If you have a question, post in the chat, and then we shall have Dr. Nansubuga attempt to any of them that are coming through. Thank you. Over to you, Dr. Nansubuga.
Good afternoon, everyone. I'm pleased to give in a case presentation. I'm pleased to give in a case presentation on abdominal trauma. I'm by the name of Dr. Nansubuga Maria Sumta, and I'm a medical officer by profession. So I'm presenting MR, a 38-year-old male who was a motorcyclist with no known chronic illnesses. He came in with history of being involved in a road traffic accident about 4 hours ago, where he had collided with another motorcyclist and fell off his motorcycle. He fell by his right side of the body after which he developed worsening generalized abdominal pain, which was exacerbated by change of position. He also reported history of headache, loss of consciousness for some time. However, the time was not specific, but there was no history of any convulsions, any vomiting, any bleeding from the ears, nose, or CSF flow from the ears or the nose. So we went straight to do the primary survey. We started with the airway and the spine. The airway was clear, he was able to talk and he was able to support his neck. Therefore, no intervention was made. We went into the breathing, which is B. The respiratory rate was 18 breaths per minute. The SpO2 was 96% room air. His chest was symmetrical. It was moving with respiration. There was no chest tenderness, and there was bilateral air entry with no added sound. The intervention was to give him oxygen by nasal prongs as required for any trauma patient. So I went into the circulation. He had warm periphery. The capillary fill was less than 2 seconds. He was tachycardic with a pulse rate of 111 beats per minute. He was hypotensive with a BP of 100 he was hypotensive with a BP of 85 over 53 millimeters of mercury. Heart sound 1 and 2 we had with no added sound. So the intervention, we established 2 large bore cannula, gave him 1 liter of normal saline. Meanwhile, we also picked up blood samples for grouping and cross-matching and other tests. Immediately, we requested for 2 units of blood. However, he was B negative, therefore his blood was delayed. We had to mobilize blood from the blood bank. We also had a transurethral catheter put to monitor his urine output. And also check the color of the urine, which was clear and not blood stained. So that went in to do the disability. He was drowsy. However, he was well oriented in place, person, and time. His Glasgow scale was 14 over 15. Eye opening was 3. He would only open the eyes when called or when we were talking to him. His verbal response was 5, was well oriented, and the motor was 6, would obey commands very well. The pupils were equal and reactive to light. He had a soft neck. He had normal power in both limbs and with an intact sensation. The random blood sugar done was 6.7 millimoles per liter. So we went in to do the exposure. He had facial and scalp lacerations. An STS was done. The chest wall had no bruises or tenderness. All the 4 limbs had no tenderness and no bruises. However, per abdomen, it was of normal fullness, symmetrical. It was moving with respiration, with generalized tenderness and guarding with rebound tenderness. However, we could not go in to check on the masses in the abdomen because of the much tenderness. The rectal exam was normal and there was no rectal bleeding observed. The back, there were no bruises, and then there was no thoracic or lumbar bone tenderness. controlled his pain with IM tramadol, 100 milligrams. That we then did an EFAS, which was positive. He had hemoperitoneum with grade 2 liver injury. He had no free fluid in the chest, no fluid in the pericardium, and there was no pneumothorax. So he planned for a brain CT and then an abdominal CT. Meanwhile, we gave him IV tranexamic acid, 1 gram. That so we did a sample history, our signs and symptoms. He had generalized abdominal pain. He had facial and scalp lacerations. He also had history of loss of consciousness for an unspecified time. The allergies, he reported no known allergies. Medication, he had no history of any daily medication or recent medication. Past medical history, he had no history of any chronic illness. The HIV cell status was not known, had last tested about 2 years ago. Had no history of any surgery, major trauma, or blood transfusion. His last meal was lunch, which was roughly about 5 hours ago. So the event, he reported he had collided with another motorcyclist and fell off the border, but he was not sure where he had fallen off.
Pressures keep fluctuating. Do you have a robot? What is
So like I was saying that the event, he had collided with another motorcyclist, but was not.
Dr. Nasuga, kindly speak up. We cannot hear you anymore.
Hello, can you hear me right now?
Yes, we
Sorry
can
about
hear
that. All right. So I was saying that in the event, he had collided with another motorcyclist. However, he was not sure of the events after. All right. So let's another slide, please. I'm done sharing the slide. Thank you. So our problem list, 1, we had hypotension due to possible intra-abdominal bleeding, and it was secondary to the blunt abdominal trauma with possible liver injury. Number 2, we had a mild head injury, and number 3, we had a soft tissue injury. So that was our problem list. So went into the follow-up. So let me give you the follow-up. So we did a brain CT, which was normal. The abdominal CT showed hemoperitoneum with a hepatic hematoma. General surgeons were informed to review the patient, and they scheduled the patient for an emergency X-lab. The patient was, however, first admitted to ICU for BP stabilization. Meanwhile, the patient was given IV ceftriaxone 2 grams, was also given IV metronidazole 500 milligrams, was vaccinated with tetanus. He was given IV paracetamol for pain, and then he was also given more fluids as he was transferred to ICU. Next slide, please. So more of the follow-up on the patient. An X-lab was done that very day. And then they found a deep laceration on the right lobe of the liver, which was actively bleeding. Abdominal packing was done, until no bleeding was observed. The gut, the spleen, the gallbladder were normal. The patient was still transferred back to ICU for close monitoring and then pain control. The pack was then removed after 48 hours, and upon removal of the pack, no bleeding was observed. Patient was then transferred back to ICU for at least 24 hours for pain control and monitoring. Patient was then transferred to the ward, where he was discharged on oral antibiotics and analgesics after 7 days of hospital stay. Thank you so much.
Thank you, Dr. Maria, for the case that you presented to us. And thank you to everyone who has been tuned in and listening in. Once again, we request, in case you're tuned in, please mute your mic unless you are talking, and turn your video off unless you're submitting something. Thank you. So as we have seen, we've listened to a case of a 38-year-old male who sustained blunt abdominal trauma. I don't know if anyone in the chat or in the Q&A has a question to Dr. Maria, or everything has been clear to us. So most of the people are thanking you. I think the case was clear to everyone. Any questions in the management? Anything that wasn't clear to you, or you think she should clear up? Dr. Kenneth Chigozi, kindly unmute and pose your question.
Good afternoon. I don't know if I can be heard.
Yes, you're very audible.
I was kindly asking why was tranexamic acid given in this patient?
Okay, thank you. I'll take 2 questions, then I'll hand over to Dr. Maria. Anyone else with a question? So Patrick is asking, Dr. Maria, can you take note of these questions so that you can answer them at once? Was a CBC done for the patient? And then Hillary is asking, what was done in the secondary survey? Dr. Gideon is asking, how do we do abdominal packing? Patrick is asking, okay, it's a comment. Then Tinka is asking, was the brain CT necessary? So I'll take the 4 questions and then we'll come back to other questions. Dr. Maria, kindly unmute and answer I hope you've taken note of them. Do I need to re-echo for you?
Not really. I've taken note of all of them. The first one was why tranexamic acid was given. The tranexamic acid was given because this patient was bleeding, and then there was a delay of trying to, okay, we were sort of trying to find means of stopping the bleeding, because the definite management was to do an X-lab, but there was a delay because of his blood. So we tried to give him tranexamic acid for us to try to do that, to stop the bleeding, sort of to help on coagulation. Then about whether the CBC was done. Yes, the CBC was done, but surprisingly, it was still, the HB was still within the normal ranges. However, subsequent CBCs were done, and the one was showing an HB of 7. And then how abdominal packing is done, that one I may not be able to answer, but however, the surgeon will be able to give how the abdominal packing was done. Then the last question is whether the CT was necessary. Yes, the CT was necessary because our patient, one, had come in with history of loss of consciousness for unknown period of time, and then even the GCS. Thank you so much.
Thank you, Dr. Maria, for clarifying on that. So some of the questions here are going to be discussed by our experts. The question on abdominal packing, I think Dr. Hans will help us on that. And then still from Dr. Gideon, another question to Dr. Hans. I think I'll forward this to him. Is there any other alternative to treatment for the liver laceration than packing? Dr. Hans will help us answer that. He's online. And then I'll ask Dr. Sunday to help us attempt some of these questions. The need for oxygen therapy, and then possibly you can also help us answer the role of tranexamic acid in trauma generally. And then oxygen therapy, must every trauma patient be put on oxygen? I think that's a question that is recurring for everyone. So Dr. Sunday, kindly help us attempt to those questions.
So thank you so much for those questions. Let me start with the issue of the oxygen therapy. From the history of this patient is that this patient had loss of consciousness for an unknown time, but the patient later regained the consciousness. So this is meaning that this patient may be having an ongoing traumatic brain injury, which needs to be observed. I know that from the literature is that any patient who has had traumatic brain injury, you need to keep this patient on oxygen because the oxygen demands for the brain will be a little bit high. So at least you can keep on low levels of oxygen as you're observing this patient. So that's why the patient needed oxygen, even though when you did the pulse oximeter, it gave you readings which are a little bit high, which are a little bit in the normal range, but you may not really consider them so much because also this patient has hypotension. So whatever is being read may not be really accurate because the patient is a little bit also compensating. So it's necessary that you keep this patient on low levels of oxygen as you're monitoring. Then the issue of the role of tranexamic acid. This patient is bleeding and you're not sure of where this patient is bleeding from, and may go on bleeding until to levels where you may not really recover the patient. So it's better to give tranexamic acid to enable the clotting of the blood, managing the patient conservatively. But the role of tranexamic acid is highly debatable. Some people say it has a role, some say it doesn't have a role. But at least with the new information, say that at least tranexamic acid has a role in patients who have got the blunt abdominal trauma. Thank you.
Thank you, Dr. Sande, for that. Maybe the team online will go ahead and look up on that. There are several studies that have recommended use of tranexamic acid, mostly for trauma patients. If you should give it within the first 3 hours of trauma, it helps to. It's been shown that patients who get tranexamic acid, it helps with the bleeding, reduce the level of bleeding for them. So you could look up studies around that area for your clarity also. But yes, it has a role. Dr. Hans, kindly help us attempt some of these questions.
Thank you very much. I think it would be appropriate if I attempted to answer them after my presentation.
Okay.
Cover everything.
Okay, thank you. So Dr. Hans will attempt to the surgical care for these patients who have sustained abdominal trauma. So some of the questions in the chat have been answered. The role of oxygen, the role of surgery, Dr. Hans will attempt that at the end. And then what anesthesia approach did they use for the patient, for that patient? I don't understand what the question is. Did this person want to ask, possibly you can unmute yourself, Ben Mhozi. I don't know if you meant intraoperatively or in the emergency room. Your question doesn't seem clear. Okay, he hasn't. We'll move forward. Okay, thank you, everyone. I think I'm going to bring this to a close. A last one from Charles. What was the indication for continuing oral antibiotics after 7 days of IV antibiotics? Dr. Maria, possibly you can attempt that, and then we bring this to a close. Dr. Maria?
Yes. The role of that one I may not clearly answer, but I think it was a routine. It was given the antibiotics are given as routine antibiotics for the patient to at least be on oral antibiotics for at least 14 days.
Okay, thank you. Dr. Hans will help us attempt to that at the end. So thank you, Dr. Maria, for the case. It came out very clearly, and we shall move on ahead to emergency care for a patient in the emergency room. For all of us who are working in accident emergency or who see these patients first, you are the health center 3, you are the health center 4, and you're the first person who has received the patient undergoing abdominal trauma. I know several people put in their expectations. People wanted to learn what is the emergency care for any patient who has had an abdominal injury or abdominal trauma in case they come to the health center 3, health center 4. So we welcome Dr. Kithula Hagai, who is an emergency physician working with Ministry of Health. You're welcome, Dr. Sandy.
Yeah, thank you so much, moderator. They have introduced me. I think we can go straight into the presentation. I know along the way we shall go discussing with Dr. Hans, because some of these things really cut across between emergency and surgery. Some of the points may be shared. So we will be chipping in along the way as we're discussing. So the pictures presented here shows us this is that we have abdominal trauma, and has divided. We see the man who is stabbed there. We have the penetrative abdominal trauma, and also you can see that car accident there, where we have the lady who has fallen flat on the tarmac with the abdomen first on the ground, which may be representing the blunt abdominal trauma that we have in this patient here. So that picture there tells us a lot that we are going to see through when we are doing the examination of this patient, when we are doing the secondary survey. Why we need to do the secondary survey, that will demonstrate why. So also the one with the knife, I request that as we go along the presentation, keep these pictures at the back of your mind, because they'll be informing us how we are going to experience. And these are the things that we have been experiencing in our communities, in our hospitals, from lower health centers up the level of the national hospital. So I said that abdominal trauma is a serious condition that requires prompt evaluation and management. The abdomen contains several vital organs that can be injured due to various causes. And some of the causes, we know them, like someone can fall from a height, someone can be stabbed, you can have gunshot wounds, you can have a crash, like accident like we have just presented. All those can happen and can be the serious causes of the abdominal causes of injuries to the abdomen. So in this presentation in particular, we shall look at the anatomy briefly, look at the epidemiology, mechanisms of injury, initial assessment, where most of the people are putting their attention, diagnostic testings, management, specific injuries, their complication, prevention, and then the conclusion. Someone asked about what prevention measures do we have on the public health aspect. I think they'll come in at that very point. So looking at briefly at the anatomy, this is just to give us an overview of what we see when we open the abdomen. We shall see from top to bottom that we have the vessels, that we have the diaphragm, which is coming in there. It's one of the structures that can be injured. We have the esophagus, which is just coming into the abdomen. Then we have parts of the spleen. We have the pancreas. We have the kidneys, which are retroperitoneal. Then we have also the duodenum coming in. We have the other vessels, the aorta and the inferior vena cava, and also there are dissections. Then also have the intestines that are coming in, the ascending colon, and also have the sigmoid and the descending colon coming in there. Also, downwards, we have also the bladder that's coming in and the rectum. So just keeping this picture with you, because we shall know that from the anatomy, that from the mechanisms of the injury, some organs are affected differently. And it's better to know which organ is where. From the clinical presentation, we shall be knowing that this presentation may reflect that the affected injury is here, either it's retroperitoneal or it is in the abdomen. So looking at the abdominal cavity, we have to divide it into three areas. Looking at the thoracic abdomen, in here we have the liver, the spleen, the diaphragm, and the stomach. So why we talk about thoracic abdomen is that you find that some parts of the contents of the liver, they go deeper into the thoracic cavity. They may be guided by the ribs, but when the trauma, when someone is involved in trauma, the ribs can fracture and end up affecting parts of the abdomen. So those structures that are in the thoracic cavity can be affected greatly when someone gets blunt abdominal trauma, even in the chest. So don't just forego that maybe nothing has happened if you are only dealing with the chest, but also if you have a trauma in the chest, also think about structures that of the abdomen that are within the thoracic cavity. Retroperitoneal abdomen have the kidneys, the ureters, pancreas, and the duodenum. These are generally protected, but they can be affected in terms of when someone has deceleration injuries. These can be affected so much. Then in the true abdomen, mainly we have here the small intestines, the colon, and the bladder. In this case here, the large and small intestines are more vulnerable to rupture with the blood abdominal trauma. Also, the bladder sometimes is also protected by the cystis pubis, but when you get blood abdominal trauma, it can be affected. So looking at the epidemiology, worldwide almost 20% of cases are related to trauma that appear in the emergency department. Here in Marara, I got a research from Marara University, which was done in about 2016. We have wrote it, I didn't send a research that has harmonized the country-wide statistics, but here in the Marara General Referral, almost 14.25%, they are abdominal trauma. And of those, 87.5 are blunt abdominal traumas. So here in Uganda mainly, another side is done in Soroti, we find that we have more of blunt abdominal trauma. I think compared to USA where they have penetrative abdominal trauma, guys like shooting themselves there. But here in Uganda, mainly we have blunt. Males are more affected, and we know the reason why. These are the people who are always on the borders, they're making borders, they're in infrastructure development. They expose themselves so much than the females, and they end up having all these. So the common causes here, we have the abdomen, we have the motorcycles, the motor vehicles, the falls, and also the assaults that are coming in. So the mechanism of injury, as we say that we have blunt abdominal trauma. So blunt abdominal trauma, in this case here, the abdomen is intact, but something, depending on the velocity, has hit you in the abdomen, and that kinetic energy is transferred from that object into your abdomen and into the structures, all solid organs within the abdomen, but also areas that are storing maybe less air, trapping air within themselves, like the intestines. All of them can be affected. So blunt abdominal injury means that here you've gotten injury or pressure on the abdomen, but the skin is intact. So compared to penetrating abdominal injuries, here a foreign organ or a foreign body has penetrated your skin. It has
Why?
Okay. So I'm saying that in acute abdominal trauma here, you have gotten a foreign body which has gone through the skin and fallen safe into the abdominal cavity. Then also we can have those injuries may include gunshot wounds, of which once they have hit you and then into the stomach, they are going to find other solid organs, or they are going to find the kidneys, the spleen. But with guns, the direction of the blade is subjected also to the movement of the person. If the person is running or is changing position, it will end up affecting multiple organs in the abdomen. And also it can bounce on the structures like the bone and end up taking another different direction. So when it comes to ballistics, you have to do a lot of evaluation of this patient. You may end up even having a total body radiation to find out where this blade might be. Also, you can have fragments as well when it comes to that. Then the serration injuries, here you can have shear injuries that come in from, for example, you have been accelerating and eventually you stop at once. Some structures, like maybe the ligamentum of teres can rupture and end up having these injuries coming in. Also where the esophagus passes through the diaphragm around that area, those structures that are anchoring onto the body can ulcerate when you have those serration injuries. Then you can have also crash injuries. Yeah, someone is repairing a vehicle, then you end up being crushed in between. So once you're crushed, those crash injuries also can come in as a mechanism of injury. So what is the initial assessment of these patients? As we had the presentation, our initial assessment will really move along the ABCDs. This patient has gotten an accident, and you have to assess the patient in the hospital start with the ABCD. We have to know whether the airway is patent and whether it's protected, and whether the patient is able to move his neck. If the patient is able to move his neck, then you can know that the cervical, the cervical spines are a little bit stable, and then you can move on the breathing. Allowed to see how this patient is breathing, be able to feel that the patient is breathing, be able to see whether the chest is moving with respiration, and also be able to count the respiratory rate of this patient here. Because the patient, we don't know for how long has been outside there, and the patient may be going into acidosis, so you may be able to tell from the breathing of this patient. Take a quick pulse, find out how the pulse of this patient, very fast also, take the BP, then auscultate the heart and hear how this patient is responding. On the issue of also on circulation, please don't forget capillary refill. It will be telling you about how this patient is perfusing, which you don't have to forget. So wherever you are, whether you're in Health Center 3, Health Center 4, please don't forget to do ABC. Look at the disabilities of this patient here. In the disability, you have to do, you assess the Glasgow Coma Scale of this patient, find out the AVPU of this patient, and also if you cannot do the Glasgow Coma Scale, do it very fast. Look into the pupils of this patient. You may don't concentrate on the abdomen alone, but be able to look into the pupils of this patient to see whether the patient is reacting to, the pupils are reacting to light. Like the same case we had for this patient here who had traumatic brain injury, who had lost consciousness. It's better you look into into the eyes, they'll be able to tell you whether the patient is developing an increased intracranial pressure. Also in the disability, please look at do the RBS of this patient. You don't know when this patient has eaten, so be able to do RBS, because the patient may end up dying of hypoglycemia other than the trauma itself. Then come expose the patient, remove everything on the patient from head to toe, so that you're able to expose this patient and look at any other injuries that may be present on this patient. So when you do all those assessments, they enable you to intervene as much as possible. As you're intervening from the airway to the exposure, don't proceed to the other area before you finish the other. If the airway is not protected, protect the airway, get Goodell, put it there. Or sometimes in the health center 3, you may not have a Goodell, but you can reposition this patient. You can do a jaw thrust, you can do a jaw thrust, you can do chin and lift, but depending if the cervical spine is stable or not stable. So you can do those things there. Now, if the patient is not breathing very well, make sure that you put on the what? Put the patient on oxygen, but also keep monitoring the patient with the pulse oximeter to see how the patient is ventilating. Then the saturation, make sure that we shall discuss in details how the saturation of these patients, because saturation there, you have to be cautious depending whether the patient has traumatic brain injury or not, and the blood pressures that may be required. So when it comes to the secondary survey, you have to do from head to toe, assess the head, palpate that head. You go palpate to see whether there are any fractures, whether there are any lacerations. Move down to the neck, palpate the neck, find if there are any steps in the cervical spine. Move down to assess the chest for any signs of deformities, abdominal movement on the chest. Palpate that chest to find out if there are any fractures in the chest, and then also go ahead and also try to palpate the abdomen, mainly to find out if there is anything. Do just that one quickly, and also find out if this patient doesn't have any other fractures, maybe fractures of the bones, long bones in the arm, or the extremities. Then also that will consider your primary survey. So whatever you're getting from the secondary survey, it will enable you to capitalize on your physical examination in details here. So in the physical examination, I have to make this disclaimer, but also the session I think will make it. Patients who have abdominal injuries, sometimes their physical examination or abdominal examination may find them when they are normal. So it's very, very important that the patients who have abdominal injuries, you have to continuously do serial examinations of these patients along the way. You may find that when the patient has just come, you find that when you palpate the abdomen, there's no tenderness. You may find there's no distension, or there are no signs of peritonitis. But later, after like maybe another 20 minutes, you find that there's tenderness or there's distension. So you have to do abdominal examinations, you have to do inspection, you have to do palpation, you have to do auscultation. Then also make sure that in this patient, when you're doing the physical examination, don't forget to do the rectal exam. When you do the rectal exam, to tell you a lot of things. Whether this patient also has a rupture of the rectum, or there is a fissure which has formed, or even if he's a man, you're able to palpate the prostate to find whether it is still in position or it has shifted. Or you can find that this patient here may have blood on the examination glove. So it can be able to tell you that something is going on in this patient. Some of the other things you have to do in this initial assessment are the bedside examinations of this patient. Someone asked whether should we do the CBC. Some patients may be normal, and when they do the CBC, you may not see anything much. Or if there are changes, maybe due to stress, and may see maybe a deviation in terms of white blood cells, but maybe due to just stress. But the HB may be normal in some of these patients, so they may not be deranged, and they may not tell you so much. You may have to do other assessments, bedside ultrasound scan have to be done. You can do bedside. In this nowadays, you can even do bedside ABGs. You can do them, and they can tell you the state of the patient in terms of ABGs. In the lower health facilities, bedside you can do random blood sugar levels. So after doing all that, always remember to do reassessment of this patient. Reassess ABCD again to see if there are any changes before you proceed to any other thing. So these are some of the pictures that you see. Mechanism of injury, as I said, that when you're examining, you have to say to do from head to toe. You will be able to see, like for this one here, you can be able to see that this was a road traffic accident, and there's a seat belt mark. Then also someone asked that, how do I know some of the signs and symptoms that you can see in these patients here? You can have brain turner signs. In this case here of the great turner, you feel that if you look into the flanks of the patient, you can see that these bruises, you can see some kind of subcutaneous hematomas formation, which is a sign of retroperitoneal bleed. So you may think that maybe probably the kidney must have been affected, and maybe the patient is bleeding within the muscles inside there, and that one can tell even the aorta, they have ruptured, and the patient is bleeding in the retroperitoneal area. Also, the coronary sign, you can see like some kind of hematoma formation around the area of the umbilical cord. You can see that something is wrong. So you can be able to that also is a sign of retroperitoneal bleeding, and you may need an urgent intervention in such a patient. However, these are late signs. These are late signs of abdominal trauma. So you may not have to say they are not present, and so the patient doesn't have blunt abdominal trauma. This can happen in about 24 to 48 hours of this patient here. As we go ahead in the management of these patients here, out of hospital care of this patient, if there's a bystander who is qualified or the emergency technicians are there, stabilize the patient. If you have done a quick survey, see if the patient if the patient is bleeding profusely, try to achieve hemostasis, apply pressure there before the patient transferred. You can also stabilize the cervical collar, because if you're not sure what this patient is doing, if he's unable to turn his neck, put a cervical collar on this patient here. If you have a heartboard, place the patient on a heartboard, because you may have other structures injured like the spine. Also, come to the hospital, make sure that in doing the rectal exam, make sure you feel that the sphincter, if the patient may be having injury to the spine at the same time. But out of the hospital, those are some things you may have to do. You may have to put a large bore cannulas and start testing this patient. In the hospital, as we said, stabilize the patient, ABCD, as we said earlier on, you have to repeat it again and again. This patient here, you have to give fluid and electrolytes. When the goals and the principles of fluid sustain in this patient here, it will be very much dependent. If the patient has a penetrating abdominal trauma, make sure that at least, if it's penetrating, look at the systolic blood pressure is between 60 to 70. So, and if the patient is he has a blunt abdominal trauma, but has traumatic brain, without traumatic brain injury, you can keep it between 80 to 90 blood pressure. And if the patient has a blunt abdominal trauma, but has a traumatic brain injury, make sure that the systolic blood pressure is between 100 to 110. Why? Because we're looking at keeping the map of this patient above 60, so the patient is well perfused in the brain. Some other consideration here in terms of giving fluids. The best fluid to give to replace fluid will be blood. But if this patient is bleeding, it means whatever blood you're going to give, it will be getting out of this patient. So it's better to give fresh-solids in this patient. If you're resuscitating this patient, you have to give 10 to 20 minutes per kg in this patient. But also we know that we're doing, depending on the mechanism of injury, the state of the patient, we shall be doing what they call damage control resuscitation in this patient. Along the way, we are going to be monitoring this patient. Attach the patient in the hospital. Please attach the patient monitor to monitor this patient. Also monitor the urine output. As you're monitoring the urine output at the level of 0.5 ml per kg per hour. So if the patient is not giving you that amount of urine kg per hour, the patient is not perfusing very well. Then also you have to do the issue of electrolytes may come in later, but at least you have to send for electrolytes meanwhile. Then also the role of analgesia. The role of analgesia, these patients have to give them some analgesia because they're in pain. But make sure that before you give analgesia, you are fully examining the patient. Otherwise, if you give analgesia and fully examining the patient, you're going to blunt some of these presentations and they will not come out clearly. Again, give tranexamic acid as soon as possible. And I said earlier on that the role of tranexamic acid is really contentious, but at least for now, we advise that you give tranexamic acid. Antibiotics, yes, you have to give antibiotics. Why? Because these patients may have got a rupture. Remember, these patients have ruptured and blood is oozing into the abdominal cavity. Later on, bacteria is going to grow there, so you have to give antibiotics. Also, you can have rupture of the intestines, and this patient is going to become septic. So you have to give antibiotic cover in this patient. And tetanus, yes, you have to give tetanus. Most especially men are not vaccinated against tetanus. So you have to give tetanus at 0.5. Surgery should be done as soon as possible in patients who are hemodynamically unstable. You have to do urgent surgery for those patients. Otherwise, the patient will die within your hands. So we can move on. So diagnostic testing for these patients, if a patient is a little bit stable, you can do an erect plain abdominal X-ray to see if there is air under the diaphragm. It can enable that this patient has ruptured the intestines, and so you're able to know that you have to intervene as much as possible. But also the plain X-ray can tell you the air fluid levels. CT scan, please don't do a CT scan if the patient is unstable. But if the patient is stable, you can do a CT scan. It can tell you a lot and can help you to do conservative management of the patient. Then also you can do angiography. Here you get a dye, you put into the patient, and then you do serial imagings to see how the dye is leaking within the abdomen, and then you can be able to tell. Sometimes you can examine the patient and the examination doesn't come out clearly, and you feel to know that this patient here, the vitals are going low, but you're not finding out where this patient is bleeding from. You can have to do diagnostic peritoneal lavage. So diagnostic peritoneal lavage, if I can give some demonstrate how you do it, you just go into the abdomen, below the umbilical cord, make a small incision about 2 centimeters, open to see if there is any blood that may come out. If it doesn't come out, you can get 1 liter of normal saline, push it into the abdomen. Then from there, if blood comes out, you can aspirate about 2 mils of blood, send them into the theater, send them into the laboratory. Then how do you know that this is positive? So you can know that this is positive if there's red blood cells of more than 100,000. If also you can do, if you find that there is, if you know there is white blood cells of more than 500, and also if you can do amylase of 110, then also you can find that the lab can tell you that the amylase can be 1,000, 11,000. 11,000. Also, if they evaluate clearly and they find that there is bile content, also there's fecal matter, or there's food, or if they do gram staining and there's some bacteria, then you know that's very positive for that there's a rupture to the organs, rupture to the organs. So I think maybe you can you can transfer so that people are able to see those figures who are people online. Then also indications, as I said, equivocal clinic examination. We are examining the abdomen, but really it is not diagnostic. You find that you have to do that. Also, it can be very difficult to assess the patient. You may find someone is very obese and really you cannot examine the abdomen very well. You can go into that. If the patient is persistently hypotensive despite adequate resuscitation, or if the patient has multiple injuries, or the patient has a stab wound where the peritoneum has been breached, you have to go that. As I said, also other diagnostics, you can go angiography in some of the cases. But depending on where you are, you can intervene depending on where you are. So specific injuries in abdominal trauma, as I said, you may have liver injuries or spleen injuries. These may require surgery. Also can have pancreatic injuries, which can be difficult to diagnose, and also this may also require surgery. But if you do amylase and it's positive within the peritoneal fluid, then you know that the pancreas is affected. Intestinal injuries can lead to peritonitis, and this will have definitely lead to surgery. Then also can have renal injuries, which also may require surgery. You can proceed. So complications of these patients. You can have, one of the complications is that you can have compartment syndrome. So there's increased intra-abdominal pressure, and once you have an increased intra-abdominal pressure, you end up impinging on the blood supply of these organs, and so you end up having multi-organ failure because of the compartment syndrome. So it's one of the complications that you may see commonly in blunt abdominal trauma. So it's better that the surgeon assesses this patient very fast to be able to relieve the intra-abdominal pressure. You can have sepsis as one of the complications. You can have also renal failure due to decreased blood flow, but also other complications can occur, like electrolyte imbalance can come in due to a crash injury that you have just received. So those are some of the complications that may come in. So someone asked about prevention. How do we prevent these? Yes, some of the prevention measures we can have is education. You can educate about these people, how to use helmets, how to protect, to use gears when they are riding motorcycles, and also awareness of safety practices. If they are saying that this is a sharp corner, please, by that there's a sharp corner, you need to be able to navigate it and reduce on the speed. If they say here the speed is 70, reduce the speed. If they say here don't overtake, those will be some of the measures can be taken, public health measures can be taken. So abiding by the laws or the local rules can be helpful in these areas here. Don't drive if you don't have a practicing license. Don't drive when you have taken alcohol. Don't drive if you are under influence of any drugs that may impede your mental status. Then also personal protective equipment. As I said, you can use the helmet, or you can use the heavy gears. Also, we can have workplace measures that may include, you put safety, you can put indicators on workplaces. Please be aware of sharp objects, or be aware of heavy metals, so that people can know that in this workplace, this is the practice. And people will end up finding themselves in where they're being smashed by speeding objects within the workplaces. Also, we can talk about injury prevention campaign. Injury prevention campaign, workers in the workplace can say, no, I think we're not safe and we need to be protected from these injuries. So in conclusion, early recognition and treatment is important for improving patient outcomes. Prompt evaluation and management can prevent complications and reduce mortality. Future directions in abdominal management are evolving, and also new diagnostic measures and treatment are coming up. Because as we used to say that earlier on, we never had issues like use of tranexamic acid. Earlier on, every patient who had abdominal trauma, you just end up into theater, but now apparently we can observe the patient with the use of ultrasound scan, with the use of e-fast, you can be able to observe the patient and how use a non-surgical approach in managing of this traumatic patient. Otherwise, thank you for listening, and this brings us to the conclusion. You can go into Rosen emergency medicine and look into these concepts. Also, look at the American College of Surgeons and also World Health Organization. They can give you more information on this topic. Thank you so much. Thank you for listening.
Wow, thank you, Dr. Sande, for the very elaborate presentation. I believe very many of us have gotten enlightened, some have gotten questions, some have been ignited to go and read further, and some have been inspired to come and join emergency medicine. Yes, so before we look at the questions at the chat on the chat, I'm going to ask Dr. Hari to just give a brief comment on care of an abdominal trauma patient in the emergency room.
Sure, thank you, Dr. Anna, and thank you, Dr. Sande, for that very comprehensive presentation. I think a few of the points that I would probably just want to make based on the presentation and the information is, one is that the two major kinds of abdominal injuries would be blunt and penetrating. The blunt abdominal trauma is usually from that deceleration injury, and it usually affects the solid organs, the ones that are kind of moving with the momentum when you stop the car on that tree or that other car. So those are the liver, the spleen, and the kidneys. On the other hand, penetrating injuries tend to be affect those organs that are the biggest, take up the biggest space. And we're really talking about bowel. So, because when you look at an abdomen, what do you see? You see bowel, small bowel, all over the place. And so those are the things that are most often injured in a penetrating injury. I want to remind people that when we're talking about abdominal injuries, we're really talking about from the nipples to the pubis, right? Because the diaphragm can be all the way up where we traditionally think of in the chest. A few of the other points that Dr. Sande made, I think, are a little bit cutting edge. You know, one of them is the concept of not getting a normal blood. So we'll call it permissive hypotension, depending on whether there's a head injury, depending on whether it's blunt trauma or penetrating trauma. There's some pretty good data now that we don't have to bring people's blood pressures back to normal, primarily because all you do is increase the bleeding when you bring the blood pressure back to normal with crystalloids. Obviously, blood is really the preferable resuscitation fluid, especially when you know that there's a hemoperidium. I think the other thing that Dr. Sande mentioned was observing people with abdominal trauma. That's something that we do more and more, but you really have to have both the facilities to monitor people closely, the ICUs, but you also have to have the CAT scan that gives you that anatomic detail about, is it a splenic injury? How bad is the liver injury? And also following it along to see if there's a reason to go in and operate on the person. So I think those are kind of the major points in terms of prevention. I think really prevention comes down to preventing the RTAs, the road traffic accidents, maybe making sure people are wearing helmets. So when they do get the RTA on the BOTA, you're not worried about the head injury, but you can just deal with the abdominal trauma. Wearing seatbelts and road safety are kind of the very typical ways that you can prevent it from a public health perspective.
Thank you, Dr. Hari, for that overview and for the enlightenment. So we have several questions in the chat. Some have been answered, but we'll just quickly go through them. the first question that was asked was on the role of doing a deep rectal exam in these patients, but it was answered along the way. Then we had a question on how easy is it to be able to tell the gray tanners sign and the coolant sign in a dark-skinned person. In your practice, have you seen, is it something that is very easy to see in the blacks in our setting?
Can you answer that?
Yes, you could answer that as I look.
So I think in the blacks, it may not be easy to tell that this is gray tanner or coolant sign, but you may see changes in the skin. In the skin in the skin color, you may see some changes, and you say, I think there's a change in the skin, and you'll be able to tell that maybe probably this is a gray tanner or coolant sign. The pattern of the skin may end up changing in the blacks.
Okay, then I think I'll read through all the questions and then you answer them at once. So there's a question on the use of the tetanus toxoid versus the immunoglobulin in a patient with an acute injury. So in a blunt abdominal trauma, someone thinks we should give the immunoglobulin instead of the TT. Maybe you would comment on that. And then Isaac Keith wanted to know why you suggested that we give crystalloids instead of blood for a patient with hypovolemic shock. He thinks that the fluids would instead cause hemodilution. And then there was a question on the peritoneal lavage, that what findings from the aspirated blood in the hemoperitoneum are we interested in when we send the sample to the laboratory for assessment? I think that was answered.
Yeah, I answered that.
Yes. Then there was a question from Masereka Abraham. He says, can't abdominal quadrant tapping be used to confirm hemoperitoneum?
I did answer that too.
Then, oh, okay. Pretty of the questions were answered by Dr. Harry during the session. So in case you're looking out for the answers, you could just go over the chat. Some of them were already responded to. So in the interest of time, we will have Dr. Hans attend to the surgical management of a patient with trauma. So Dr. Hans, over to you. You're welcome.
Good evening. I hope everyone can hear me.
Yes, you're very audible, Dr. Hans.
Those are my names, and that's my address, and that's my contact. I'll go straight to, I have 2 slides, so no worries about time. Next slide, please. Now we've looked about, and we've been considering what is the mechanism of injury. And I'll go just straight to the key points. Now, is the patient stable? And when we are saying stable hemodynamically, we are looking at the blood pressure systolic. Is the systolic above 90 or it's below 90? Is your heart rate increasing when it's above 90? Now, if your patient is not stable, you're going to do an ultrasound scan. And the ultrasound scan here is basically more focused assessment for sonography, trauma. And we are looking at the areas where fluid can accumulate. The abdominal cavity, the pleural space, and pericardial space. So the ultrasound scan person should be able to tell you that there is a fluid in the abdomen or in the chest or in the pericardial space. For our case, we are interested in the abdomen. So if the ultrasound scan is positive, that is the hemoperitoneum, we will prepare the patient for an exploration laboratory. That's how simple it is. And your options depend on what you find intra-home. And you better be prepared. Don't take a patient to theater when you don't have someone who can give you general anesthesia. Don't take a patient when you can't afford to have the instrument, the basic things, the gloves. So be prepared. And so whatever you find will guide your next steps. I'll just touch on a few things. For example, you have liver injuries, which you should be knowing while in what grade of liver injuries. The options are pretty simple for our setup. We will discuss just things that we can do, let's say in Moroto or in Arua or in Kanuni. You have a liver laceration that is actively bleeding. The next steps are you must have abdominal mops. You can do packing in 4 to 6 mops. If you have Sadicil or you have any other gel that can cause hemostasis, that's okay. If there is a visible bleeder or blood vessel, you need to address that. So those are the options you have. That answers the first question someone asked me. Is there any other option to packing? In our setting, in our rural setting, the best and the cheapest option we have is packing. The majority of us have not seen Sadicil, so we can't be advocating for things that we can't afford. But the other options for settings that are high-tech are there. Okay, you can do non-anatomical removal of affected part of the liver and so on. Now, if it's the spleen, again, what grade is it? Can you do splenography or can you do splenoplasty? Again, for your setting, you're better off doing a total splenectomy.
Dr. Hans, kindly try to be more audible. I think the audience is not getting you very well.
Okay. Can you hear me now clearly?
Yes, but there was an echo.
You still have an echo? Do you still have an echo?
No, it's now clear. You can go ahead.
Okay. So sorry, I had to change the device. So I was describing just briefly. I had said maybe for the audience that in the incidents that your patient is not stable hemodynamically, your blood pressure is low and your heart rate is going up, and you do an ultrasound scan and it shows you the hemoperitoneum, so you prepare the patient for an XLAP. And discussed about the options if you find a liver laceration. Now, if you find a splenic injury, you do not have any big options. You have to do a splenectomy. Now, someone may ask, are there options of picking some splenic tissue and implant it somewhere? Well, current evidence doesn't encourage that, because after splenectomy, we will give the vaccine. Now, if you find the liver is normal, the spleen is normal, the stomach is okay, the small bowel is okay, the large gut is okay, the bladder is fine, and then you find the hemoperitoneum. Most likely the culprit that is bleeding is the omentum. And it's very insidious, you can't see it, so you have to be very careful while inspecting and be patient, okay? Now, if your patient is stable, your BP is okay, your heart rate is fine, the questions you ask yourself are, is the patient alert? In this case, our patient had mild traumatic brain injury, and people were asking, why did you do a CT scan? That was the indication. Is the patient intoxicated? A majority of our trauma cases are a result of drink driving. And sometimes if someone is intoxicated, you want to know whether the effects of the hypotension are the ones causing a decrease in the GCS, or it's the alcohol the person took. So if the patient is alert, not intoxicated, your next option is to ask for an abdominal CT scan if you have it. If you don't have it, then you will resort to serial examinations. And that takes about 8 to 9 hours. You do not discharge the patient. Again, after 6 to 8 hours, you reassess the patient. If serial exams and the patient is stable, then you can discharge. If you can afford a CT scan and it's positive, now the role of the CT scan is to grade for you the injury. And it has a higher sensitivity and specificity compared to the abdominal ultrasound scan. The grading of the solid organ injuries is best done using a CT scan. So if someone did for you an abdominal ultrasound scan and told you there is a grade 4 liver injury, you can't take it with a lot of confidence. So the CT scan will help you confirm whether there's blood or not. But again, to will grade, if the CT scan shows you there's a grade 1 liver injury, you can monitor. If there's a grade 1 splenic injury, you can monitor. If there's a grade 1, rarely, but it may show you an injury involving the pancreas. If it's injury involving the bowel, it may be difficult to see. Again, if the CT scan is significant, you admit the patient and monitor. And we recommend that the person who does the monitoring is the same person who does the follow-up. So on admission, if let's say Dr. Mark saw the patient, he should be able to monitor the patient after 6 to 8 hours. He should be able to reassess. You do not hand over because it's you who saw how the patient was on admission. Now, if the patient is alert and not intoxicated, we ask for an ultrasound scan. If it's negative, we do serial exams and consider discharge, plus or minus a CT scan. If the patient the ultrasound scan is positive, but our vitals are okay, we can do a CT scan if we have it in our setup. If we do not have, we can choose to observe the patient overnight. If the CT scan comes back and it shows you that there is an injury of the liver or spleen or any other organ, you have to debate. The debate now is between non-operative management versus laparotomy. Now the details, because of the audience of our session today, I'm not going to go into the technical details because we have a mix of people attending to our session. And the last part is you discharge the patient. Next slide, please. So what I've described is an algorithm you can use to manage blunt abdominal trauma. Now, the next one is basically how do you manage penetrating abdominal trauma? In this slide, I have concentrated on the anterior abdominal wall stab wounds. Earlier on when Dr. Sunday was presenting, he showed you some pictures. Now, I have not gone into stab wounds involving the back, the flank, or thoracoabdominal, because those are a little bit complex for our session. So strictly to stab wounds in the anterior abdominal wall. Now, what are the indications for surgery, immediate surgery? Now, if the team has stabilized and you find the patient is hemodynamically unstable, that is an indication that you need to do surgery for the patient. If there are features of peritonitis when you palpate or when you examine the abdomen, you need to operate that patient. If there is impalement means that when you examine the patient, you find either there is a knife in situ, there is an arrow you can see, or you've broken pieces of glass or metal, and they're still stuck on the anterior abdominal wall. And those ones need to be worked on in theater. If you have any part of the internal organs seen in the outside, evisceration, you can see the omentum, the small bowel, you need to prepare this patient for surgery. If you have frank blood from your NG tube, or when you did a PR and there's blood on your examining finger, this patient must be prepared for theater. Now, if the above are not present in your patient, you're going to do simple things. You're going to perform a local wound examination. Now, local wound examination does not refer to poking your finger to the site of injury, which is very common in rural setups. Please do not attempt that. You are going to explore the wound of the patient. It's a bedside procedure under slight sedation and local anesthesia. And it's the sterile procedure. So by a combination of blunt and sharp dissection, you're going to explore the wound. The objective is to see whether the integrity of the rectus shield has been breached, the fascia. Now, if you do local wound examination and the rectus shield is intact, then you can manage the patient as per the wound that is present. You can do STS and then the same protocol you use for managing minor wounds. If on your local wound examination, you find there is breach of the rectus sheath or the fascia, then you're going to admit the patient for observation. You're going to monitor this, the vitals every 4 hours. You do serial exams every 6 to 8 hours, and you're going to do your blood counts. Here, we're interested in the hemoglobin and the white cell count every 8 hours. Now, on admission, if you do the above and your patient develops hemodynamic instability or features of peritonitis, you transport them to the operating room for laparotomy. If on admission, your patient doesn't develop any of the above symptoms or signs, but if you repeat your CBC and you find a drop of the HB, for example, if on admission, your HB was 13, and then 6 to 8 hours later, you repeat your CBC and the HB has dropped to, let's say, 9, then there is significant bleeding somewhere, okay? Or on CBC, you see the white cell counts are rising. So you evaluate your patient. So if the above are present, you're going to do an evaluation. Possibly in your setup, you don't have a CT scan, it is physical exam that will help you. With experience, you'll know which patient to take in or not. If the above are not present, you can discharge your patient and give clear instructions on when to come back. Now, if you examine the wound under local wound examination and you find there's no breach of the rectus sheath, you manage the wound locally and then discharge your patient at appropriate time, okay? Now, there's a difference between an E-FAST and a FAST. The extended focused assessment, we're basically looking at fluid, what is present in the abdomen. If someone did and they commented that there is a ruptured spleen, that is an E-FAST. An E-FAST basically tell me there's fluid here, there's fluid in the chest. Now, your dilemma is that if the patient has, for example, had features of mild traumatic brain injury, is it the one causing a lowering in the vitals? Well, if it's the intracranial hemorrhage, then it can affect your BP. Just change the GCS, but your BPs will remain normal or may go up actually. So that is the next thing. Now, sometimes blunt abdominal trauma, you have other injuries that are present. You check your blood pressures, it's lowering, you have to examine for extra abdominal causes, especially pelvic fractures or fractures of the long bones, the femur in this particular case. To end my presentation, I'll give you a case scenario. About last year, in December, we received a young female who was at term. She was pregnant and she fell off her bed with her abdomen fast on the ground. So she came to a hospital with a complaint of general abdominal pain and decreased fetal movement. So we did an assessment and she was pale, her BPs were low, and the fetal heart sounds were irregular. So and we thought she had a ruptured uterus. So we took her to theater, we opened, we found an intact gravid uterus, no blood in the peritoneum. And we did deliver the baby via a lower midline incision on the uterus, crescentery. The uterus was intact. So the dilemma is, was the patient having a ruptured uterus? Why were the BPs low? Why was she pale? On further exploration, the patient had retroperitoneal hemorrhage involving zone 1, which is the central medial, both zone 2s, that is the lateral aspects, and zone 3 was spared. So in the pelvis, there was no blood, but there was a huge chunk of hematoma, which was retroperitoneal, and we did not touch it. And that is the approach. If it's not causing you any problems, you can't see any bleeding, you leave it. And the patient is alive up to today. Thank you very much. That's the end of my presentation.
Thank you, Dr. Hans. I hope that was very elaborate. That was very in point. For us who had questions, in the surgical management. I hope we've been answered. There was a question Dr. Siva had asked, when do we consider surgery? I hope through the presentation of Dr. Hans, that has come out very clearly. So we have a few minutes left, and there was a comment of, where do you leave the nurses in all this care? Yes, so we have an expert, we have a critical care nurse, who is going to show us how do we care for a patient who is having abdominal trauma in the emergency situation. You're welcome, Molly.
Okay. Good afternoon once again. I've been already introduced. We are going to look at the nursing care management given to this patient at A&E or at the emergency department. Our approach is not different from that of the doctors. So for us, we start with a capital C and then a ABCD approach. So I'm going to explain the ABCD and the nursing interventions we do as nurses. So we are going to start with a capital C, whereby the capital C represents controlling hemorrhage. Once you get a patient with an external hemorrhage, you must control the bleeding before you proceed to any other things. We can control bleeding by rupturing the affected area on the abdomen with extra gauze, and maybe you strap it. In case you have a patient who has an equipment, let's say a knife, what and what, you don't remove it, because this is done from theater. So you don't remove it, just cover the way it is. And in case you have a protrusion of abdominal organs, let's say the intestines, don't push them back, just cover them. Then we proceed to the airway. As Dr. Sandy had discussed about this, you talk to your patient. If the patient is able to talk, then the airway is patent. But if the patient is not able to talk, first and foremost, when we are doing this primary survey, we use what we call look, feel, and listen. So using that, on the airway, you look for the chest movements, and you also have to open the airway. But in cases where you suspect a C-spine or the patient is having multiple traumas, you use a jaw thrust, not a chin lift. What you do on the feeling, you feel for the breath sounds using your cheek, and then you also listen for a stridor or a quiz. And in the management, in case you have maybe a foreign body in the patient's airway, you remove that foreign body. But if it's very far, don't attempt to remove. But if it's very near, you can remove it, or you can use a Magill's forceps to remove the foreign body. And then if you have liquid secretions, you can suck them out using the suction tube. To maintain your airway to be patent, you use an OPA. In cases where we are suspecting a patient to be with where we suspect a patient to have a head injury, more so at the base of the skull, please don't use the nasopharyngeal airway, because you might herniate into the brain, causing more complications. Then on the side of breathing, we've finished A. Then on the side of the breathing, you have to listen or auscultate and see whether you have equibilateral air entry. And then on the side of you're looking at the chest movements, you listen for the equibilateral air entry, and then you have to examine on the chest to see if you have a tracheal deviation, which might bring to you that the patient is having a tensional pneumonia. On the side of management of breathing, if the patient, remember, as Dr. Sandy said, if you're in the hospital, as soon as the patient reaches in the emergency department, you connect the patient's monitor. So if you have connected your patient's monitor, remember, On the breathing part of it, we have to monitor for the SpO2. SpO2. So if you put the SpO2 probe, your patient is not saturating well. At this moment, we consider the normal SpO2 to be between 94% to 100%. If the patient is below those saturations, you deliver oxygen according to what you've measured. But most of these trauma patients, especially those ones with a penetrating abdominal trauma, their airways, most of the time, it's always compromised. So you putting a non-rebreathe or nasal prongs, you're just worsening the conditions. If the oxygen saturations are really too low, or let's say 60%, you can do a back mask ventilation as you inform someone to call in the anesthesiologist or the intensivist to come and maybe intubate the patient. So as a nurse in that role, you have to know the requirements of setting up an intubation tray for the anesthesiologist. Then on the part of the saturation, we monitor, basic things we monitor about these patients with abdominal traumas. As previously, they've discussed that these patients, most of the time they present with hypotension. So we as nurses, we have to monitor for the what? For our blood pressures. More so in this case, we are looking at the systolic. The systolic should not go beyond, below 90 millimeters of mercury. Then we have to look at our heart rate. Most of the time, these patients with abdominal trauma present with a tachycardia. Then we have to monitor our urine output plus our capillary refill. The normal urine output per hour is 0.5 mils per hour. So in this case, as a nurse, we enable the team, we get an IV access, but it has to be of a larger gauge. Most of the time, we get 2 lines. We take off blood samples for grouping and X-match and all other things like coagulopathies. We also aid to give fluids as they had discussed earlier. And then we also have to catheterize the patient because we said we must do what? Monitor the urine output. So the C is finished. We are going to the disabilities. As we had discussed earlier, on the disabilities, you find out on the patient's levels of consciousness by using A, VPU. I think most of us know that. A means alert, then V, the patient responds to voice, then P, the patient responds to pain, and U, the patient is unresponsive. So, still on the disabilities, we monitor our blood glucose levels. We take off the RBS. We also monitor the temperatures. And then on the E, we look we look for bruises or any other injuries apart from the main trauma that we were looking at. When you're using this ABCD approach, you first deal with the first things first before you proceed to another later. And then, as we've discussed earlier, the surgical management, some of these patients, especially those patients with a blunt trauma, then they don't proceed to go to be done a next lab. So in this case, these patients are admitted to the ward. In case the patient is hemodynamically unstable, most of the time the patient is admitted to ICU for close monitoring. But for the other cases, when the patient is hemodynamically stable, the patient is admitted to the ward. that is surgical ward. So for the continuous monitoring, in case the patient is admitted on the ward, we as nurses, we are encouraged to do vital observations, the BP, the temperature, the SpO2, the respiratory rate. So in this case, we are advised to do our vitals. They say 4 hourly, but me, I prefer 2 hourly on the ward. And then we have to do a neurological assessment. For example, scoring the patient's GCS. And we also have to do some abdominal examinations, like for example, if you're with the patient, you have to assess for abdominal distension, tenderness, generalized guarding. Remember, as we were discussing, doctor told us these patients keep on changing. For the time, you may not see the need of the surgery, but then as the time goes on, you might find the patient develops signs of peritonitis, which calls for an urgent what? Surgery. Then we have to control pain and manage pain too. And then the urine output, we talked about it. You have to observe the amount they produce hourly, the color, and then not forgetting the psychological support to our patients, and wound care plus infection control. So on the part of the critical care part of it, most of these patients, we admit them in ICU as HDU patients. For a patient to be considered as an ICU patient, that patient may be on mechanical ventilation, but sometimes we admit these ones who need close monitoring. So nurses in the ICU, they go a little bit deeper in their care, but it doesn't differ much from that on the ward. So in the ICU still we do the same things. We monitor all our nursing care is based on system per system, but I'm not going to go into details of that due to the limited time we have. But in ICU, I want to talk about the respiratory monitoring of it. If the patient came in as an ICU patient, the patient is on mechanical ventilation, we monitor this patient to see if the patient is getting into respiratory distress by looking still at what we talked about, listen for the breath sounds, see whether you have echobilateral air entry, and most of the times these ventilators can give you alarms and you manage accordingly. Still in monitoring about the ICU in the respiratory distress, in the case patient in case the patient gets respiratory distress, you're in ICU, you can offer this patient with an FiO2 or oxygen therapy of 100% on the ventilator. You can do suctioning or change the mode if the patient was on a mode which they can work together, you can change into a mandatory mode. Then you can do also tracheotoilet to relieve the thick secretions. If all these fail, you can bag the patient as you find out what is the cause of the problem. So for the other patients who came in as those ones that need close monitoring, in case you do all those things of the patient is hypotensive and you do all those things of fluid resuscitation, maybe you've given blood and the hypotension is still not improving and the patient is not having signs of peritonitis, maybe the patient needs surgery, you can give vasopressors, but most of you, the vasopressors, you know adrenaline, but in this time, or in this case, we don't give adrenaline because of the tachycardia. The best drug of choice is noradrenaline because it targets only the BP, not the heart rate. That was my presentation. Thank you.
Thank you, Molly, for being precise and on point. we're almost getting to the end of this session for today. Thank you everyone who has kept online from the start till now, those who have joined in between. Just have a few questions that I think we will run for the next 3 minutes, and then we will do a post-session test. So one is there was a question on the role of anesthesia in this kind of setting. And then I think everyone is commenting on the role of blood. When people see blood, they want to give blood. So I would give to Dr. Harry. Comment about the use of blood transfusion, specifically massive transfusion. When do you engage the massive transfusion protocol for these patients? How do we transfuse these patients with blunt abdominal trauma or penetrating abdominal trauma? And then the use of isotonic fluids in trauma. And then Dr. Hagai will tell us about the anesthesia use in the event of abdominal trauma. I'll start with Dr. Hagai, please.
Okay, thank you so much. This has been a question people asking, what anesthetic considerations are we going to make in these patients who have abdominal trauma? In such a patient, I think we have to think about rapid sequence induction in such a patient. We want to protect the airway for the patient, and in this case, to be precise, is that when you're going to induction of this patient, you probably have to use ketamine or etobitate. Why? Because these drugs are able to keep your perfusion a little bit better. Because that ketamine increases cardiac activity, increases the heart rate. So as you're increasing the heart rate, you're increasing perfusion. And those drugs don't cause hypotension. But if such a patient you gave, maybe you did a spinal anesthesia will just cause putting of blood into the extremities, and it will lead the patient to go into progressive hypotension. So I'll consider etomidate or ketamine for induction. Then in neuromuscular blocking agent in such a patient, I would go with the succinylcholine in such a patient, so that I'm able to relax the patient very well. Then I end up having complete relaxation of the patient. And also succinylcholine, it wears off a little bit much faster, but also gives you time to perform your intubation quite better. Then for maintenance of this patient, I'll go for propofol. I'll use propofol to maintain this patient anesthesia. Why I would avoid nitrous oxide? Nitrous oxide is good, but the challenge it has is that it diffuses. And as it diffuses, remember that you have already penetrating abdominal injury, and also blood is leaking into the abdomen. So since it diffuses, it will end up causing it will end up diffusing into the abdomen, then causing distension again of the abdomen or the whole organs, leading also to compartment syndrome. So it's better that when we are going into anesthetic consideration, we think of what we're going to use as induction agent, then neuromuscular relaxing agent, and also what we're going to use for maintenance of anesthesia in such a patient. Thank you. That's what I wanted to comment on that. Yeah.
Thank you, Dr. Hagai. I hope that answered the question on anesthesia input for the patient with abdominal trauma. Dr. Harry?
Sure. So thank you, Anna and Dr. Sunday. I think the concept of we all need blood to transport oxygen, and when somebody's losing blood, you have to give them blood. And normal saline or lactate urine is part of the resuscitation, but in and of itself, it can't be the totality. And in general, fresh blood is better than component therapy. And massive transfusions are really described as greater than 10 units over 24 hours or greater than 3 units in an hour. And if you use components, then you have to replace the platelets and the plasma for the clotting factors. But if you have fresh whole blood, that's really what you need with some saline to actually provide the kind of plasma components. I think the ultimate treatment for bleeding is, yes, it's important to give the blood, but you have to stop the bleeding. And so the surgical intervention, if there's blood in the belly, you give them blood, but they have to go to the operating room for definitive treatment of the bleeding. And one thing I would say is that in my experience in a place like Uganda, blood comes a lot easier, truthfully, than it does in in the United States. It's easier to get the blood if you have it. Don't let the technology of CAT scans, the technology of ultrasounds really impair, kind of delay your definitive treatment, which is in the operating room.
Okay, thank you, Dr. Hari. I hope we are satisfied about transfusion and use of blood therapy. So we have Dr. Mary Elaine online. Kindly unmute and give us your opinion about care in a resource-limited setting. This possibly will be our last session, and then we'll bring this to a close. Dr. Mary? Oh. Dr. Mary Elaine? Okay. If she's not picking, then it's... Oh, I can't unmute. Okay, it's good to see you online, and we are glad you joined in. So I'm going to... there is a post-test running. Kindly answer, and as we bring this to a close. Thank you, everyone, for attempting today's session. We've had almost all the questions in the chat answered, and my take-home message from this session today is a patient with abdominal trauma coming to the ED, don't treat the abdominal trauma in isolation, treat the patient as a whole. And it is very important to attempt early resuscitation, either pre-hospital, post-hospital, do what you can. From what you've learned from today's session. If you have fluids, start with fluids. If you're able to get blood early, please get the blood early. If you're able to get the EFAS done early, please do it. Do early resuscitation as soon as you can. Yeah, so thank you everyone for tuning in for today's session. Dr. Hagai has a submission.
Yes, I wanted to comment on what Dr. Mary was supposed to talk about regarding resource limitations.
Yes, yes.
So I think most importantly, if you're in a health center 3, health center 4, and you've made your diagnosis that this patient has a blunt abdominal trauma, and the patient is becoming hemodynamically unstable, please think about referring the patient as much as possible. If you can identify the cause of the bleeding, just arrest it. If it is an open book, just put it on quit and refer the patient. But referral should be on your list. Call the area where you're referring so that they prepare as soon as possible, so that the patient doesn't die along the way and doesn't die on the emergency department because the patient has arrived on time, but the people there are also busy. Call them so that they prepare for the patient who is coming and end up to save the patient. Thank you so much. That's what I can comment about.
Okay. Thank you, everyone. Thank you, Dr. Hagai. So I'm going to bring this to a close. We'll have a closing remark from each of the panelists. Dr. Hagai has given us his closing remarks. Thank you. Molly, what would you want people to know about your closing remark for this session from the nursing team?
Yes, my closing remark for this session, especially to my dear nurses, I think we can do something in saving patients' life. We should stop this habit of saying everything is for doctors. Let's come on board and we save people's lives. Thank you very much.
Thank you, Molly, for that. Dr. Hari, what is your take home?
Thank you, Dr. Anna. I think it really comes down to there's no reason that we can't be aggressive in our approach to emergency patients who are bleeding in terms of replacing blood, in terms of going through the ABCDEs and the definitive surgery necessary to stop the bleeding. We can do it here, we can do it wherever we do it in the world.
Thank you, Dr. Hari. Dr. Hans, do you have any closing remark for us in case you're still on? Dr. Hans? Okay, I think he left after presentation. Dr. Hans cannot unmute at the moment. Yes, okay. Dr. Sumta, do you have any take-home message for us, for the people that listened in? Dr. Nansubuga? Okay. Possibly, she also can't unmute. Okay, but it's been a great session. I believe we can all do something. Let's not wait for the surgeon to save a life, but I think the surgeon cannot work on a dead patient. So if a patient is before you, please do what you can. And yes, thank you everyone for tuning in. Thank you to Seed Global for making this possible. Thank you to Ministry of Health, and thank you to our wonderful panelists for joining us today and for sharing your knowledge. We are very grateful. Yes, so I'll bring this to a close, and yes, thank you. See you next time. Bye.
Thank you all to all the participants who have
Thank you to all the participants who have attended today's session. For all those who are in regional and national referrals, we urge you, if you are willing to join the REACT team, we are setting up REACT teams in all those facilities. So keep an eye out if you're willing to join. And at this juncture, for all those who are still on, I request you please to turn on your videos so that we can take a few screenshots. For any questions that weren't answered, they will be answered in the National EMS Echo group. So watch out for the answers there. And at this point, please turn on your videos. Turn on your videos. And see the Masaka team joining in with me, Sauma. Thank you very much for joining. The Yumbe team, Sister Charity from Mara, thank you for joining. Yes, as we take the screenshots, thank you all for joining.
Those that are joining in as a group, we request you that you all register, because when we're offering a certificate, our system captures one person. So if you are in a group, it's good to register on that same link so others don't miss out on the certificate. And for any internationals that we have, so that some people from Nigeria, Ghana, do we have any internationals? Okay, if we don't have any internationals at the moment.
Someone from New Mexico.
We had from Nigeria, we had Somalia.
Thank you so much all for attending, and would love to see you again on the 31st. We are going to handle head and spine injuries, so please be prepared to attend the session. Thank you and enjoy a good weekend. Please do not get blunt or penetrating abdominal trauma over the weekend. All right, bye-bye, all of you.
Okay. Thank you.